So when you look at childhood mental health problems, I didn't say mental illness, mental health problems, the vast majority of it is experiential. And so you don't treat that with a medicine. And so these other things about giving supports and giving services, and heavens, just routine therapy should be part of routine well care anyway.
Welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am Grace Pratt, and I am joined by an incredible team of co-hosts this morning for a conversation I am personally very excited to have. I feel like I say that every month, but it's really true this month. We've been talking so much on the podcast these last several months about huge, larger system changes in policy and the implications for our practice across. We represent people across the country, and I know that our organization has all flavors of healthcare providers across doing integrated care all over the place. And I think this is an issue that's really impacting a lot of us. So not too many words from that right now. I want to do our introductions. Like I said, I'm Grace Pratt. I am the behavioral medicine faculty at Integris Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. And I have a whole panel of co-hosts here with me today. So going around the circle from what I see here, next I have Jen Thomas.
All right. Good morning. Hi, everybody. Jen Thomas, family medicine, addiction medicine, co-medical director at CFHA and practicing in Illinois. Yeah, it's great to be here. I brought a friend. Shall I introduce Mary briefly or after everyone else goes?
Hold on just a second.
Okay. All right. We'll save that best for last.
Spoiler alert. Yeah.
Yes. She's in the wings. All right. You go.
Excellent. Next, we have Deepu George.
Good evening, wherever you are. My name is Deepu George, and I am a behavioral health consultant, and I'm at the University of Texas Rio Grande Valley. And I'm coming back after a few episodes, but hopefully it'll be more regular from now on, right?
We're so happy for that. Our longtime listeners will recognize Deepu's voice from a long time ago, and then he took an extended hiatus as he had some other leadership positions, and now we've reeled him back in. So thank you for being here, Deepu. We also have Monica Williams.
Hello, everyone. Monica Williams, licensed clinical social worker, clinical trainer, and implementation coach with the AIM Center, lover of all things integrated care. So happy to be here.
Thank you. Then we have our leader of our organization, Neftali Serrano.
I love it when you roll the R and give me the accent on the I. Thank you, Grace. I am Neftali Serrano, or Neftali Serrano, whichever way you will say it. I'm the CEO here at the Collaborative Family Healthcare Association. I'm so glad to be here with our team today and with our special guest.
Our newest member of our podcast team, Ashley Garrison.
Thank you so much, Grace, and good morning, everybody. My name is Ashley Garrison. I am the pediatric dietitian at Burlington and Mebane Pediatrics, located in Alamance County, North Carolina.
And then, as she teased earlier, Jen brought a friend with us to join us today that we're so excited about. Maybe give the tiniest teaser, Jen, and then I'll have you say your name.
Yeah, okay. Go ahead. All right, teaser. So we have a really amazing talent with us on the podcast today. Mary is literally a mentor hero of mine. I first heard her name, I think it was 2005. I was a med student on a psychiatry rotation. I remember one of the residents was like, we have this amazing child psychiatrist. She actually used to be a pediatrician. And she's wonderful and so smart. I got to know Dr. Dobbins then in future rotations and really have kind of looked up to her as an integrated care leader and mentor over the years. So pumped to have Mary join us today. So Mary, say hi to the audience.
Hi, everybody. It is so very nice to be included with this group. I'm excited for the conversation we're going to have. And I also have to say I have the highest respect for Dr. Thomas as well. I did practice peds and went back into psychiatry. And most of my work after that training has been working with integrated care and consultation. I work at an academic center in Central Illinois.
Thank you, Jen. Thank you so much for being here with us, Mary. So we are so excited to have this conversation. We're going to dive into a little bit more, but first I want to ask Neftali, do we have any news and notes today?
Yes, and I'll be quick with these news and notes because I'm excited to get to our conversation today. By the time you're hearing this podcast, more than likely, our conference registration is open for the fall. This is going to be a really important conference for us. We are going back to the Midwest, to St. Louis. We're doing that purposefully because we think going back to the heartland, addressing the key issues facing rural America and cities and towns in the middle of the country is huge. It's obviously not just for Middle America. All of America will be convening in St. Louis with us, but check out integratedcareconference.com for registration details. It's going to be a really great event. I had the privilege of looking through all the sessions. It was really difficult to make choices. We had the most number of sessions we've ever had submitted to this conference. So we had a lot to choose from, had some hard choices. There's something for everybody there. So integratedcareconference.com for that. We also intentionally don't want to make the conference the only thing we do to push integrated care forward. So we have training experiences all throughout the year that hit different portions of the need on care teams. And so I just want to encourage you to go to our website, cfha.net, and take a look at our training experiences page. We've got several training experiences coming up. For example, there's a training on assessing your behavioral health consultants using a standardized tool, right? And there's a training coming up on documenting in integrated care settings. So things that are just really relevant, important to your teams, check out our training experiences. Last but not least, this came across my desk today, ARC, and I forget what ARC stands for, but AHRQ, Agency Health Research Quality, I'm not sure, something like that. They have a new updated financing toolkit. I haven't taken a look at it yet, but I heard about it in its development. I'm excited to take a look at it. Go on ARC's website, play with it, give us some feedback because we'd like to give them feedback. We partner with ARC all the time. So check that out. It's just a way to basically assess your program's financial health and maybe help you do some planning, financial planning that you can talk about with the folks in your C-suite around. So check that out on ARC's website. That's our news and notes for this month.
Thank you, Neftali. It's hard to keep it short when we have so many awesome things going on. Thankful for this organization and all the efforts to push forward integrated care. Okay, let's get into it. We are talking today about policy and larger system policy movements and how that is impacting our practice and I guess my big question is, what should we even be thinking about this? Because the good is mixed in with the bad and there's so much to it. So thank goodness we have brought on an expert to share information with us. So Jen, I wonder if you could give us a little bit more background about what led to this conversation today.
Absolutely. So it may have come across your guys' desks too a couple weeks ago. It was certainly in mainstream news. There was an item that came out of U.S. Health and Human Services that there was a gathering, I believe it was May 4th, with the Maha Institute. There was a summit on mental health and over-medicalization where HHS Secretary RFK was announcing a plan to reduce over-prescribing of psychiatric medications and supports for alternative treatment options and discontinuation of medications when needed. Part of what I love about this podcast is that we have such great experts, but also a pulse on the frontline clinicians, right? If this struck a nerve with me and you guys, I'm guessing it probably has, we all have some feedback and thoughts on this topic in the larger integrated care community, because that's what we do. We talk with patients every day, weighing risks and benefits of treatment with integrated care, whether it's behavioral interventions or medications or both. These are tough conversations. And when policy kind of gets involved with some of these initiatives that I think might be challenging to our work, it's definitely a good opportunity to talk through those things, see what our values are, where we think healthcare should go, and kind of have that conversation. So that's why, I was hoping to have this conversation today. And I just thought Dr. Dobbins, being a child and adolescent psychiatrist, would be a great voice to give some context and expertise to our conversation. So let's get into it. Did anybody hear this press release? Was I the only one that was like, or was this on y'all's radar too?
Absolutely. I think what's been constantly so hard for me, and I think this came up the last time we talked about the Healthy Again movement, is that they're using a lot of words and recommending a lot of things that I think are great. I teach our residents about de-prescribing for sure. A lot of times in the context of older adults and our geriatrics curriculum. We at this podcast absolutely think medication is not the only answer and that we should be supporting lifestyle change and health behavior change. And that's part of the reason why we want to promote integrated care. And I have a deep suspicion, I don't know, skepticism about some of the implications that can come through along with the ways that this is being talked about. And I feel like my reaction is, oh, I just have so many mixed feelings.
Same.
Yeah, I think it's helpful to call out that continuum of how you can respond to this. On the more cynical side, one could say that this is part of a larger effort to delegitimize Western medicine. Right. That's just on the more cynical side. You can say, yep, that's what this is about. On the less cynical side, you can say it makes sense that in a fragmented health system where a patient may accrue providers and accrue medicines through their journey in our healthcare system, that they might have too many medications on board. Now, that might be a trend to have. And it may be, you can say on that side of things, yes, among children, especially children and adolescents, we may be medicalizing some social issues there, right? So you can be anywhere along that continuum. What I try to remind myself is that most people are somewhere in the middle on that continuum, right? Most average Americans. And I think that's who we want to talk to. I think that's who we should be talking to because they do have some concerns about can they trust their doctor and can they trust their care teams? And they also have some concerns around, hey, this health system doesn't feel terribly healthy to me, so it makes me lack a little bit of trust there. Are there some things that big pharma is trying to pull the wool over my eyes, right? So wherever you fall on that continuum, I think it's important to have the conversation. And I'm looking forward to hearing what you all have to say about how to have that conversation because I'm not sure how.
I definitely agree and want to emphasize as well your sentiments, Neftali, that it is a continuum, right? Like when working with any patient, any client, any of us, we could be anywhere on that continuum. And it's important not to necessarily isolate individuals. Being able to hold space to listen doesn't mean that you agree or disagree, right? And sometimes I think we are not always willing to at least hold the space to listen. We tend to want to jump quickly to what the issue is and fix. How can we just fix it, whether that's medication or whatever? I will say so I did see it, and one of the things I'm always leery of, especially in the advocacy space, is I'm going to use Bridget, who's not here, word of context. Because what is the context of said bill, said policy, right? It's never as cut and dry as it looks when you're talking about bills and things that are being put forth to pass and we're wanting to advocate for things. It is easy to grab individuals with a tagline. Oh, we don't want everybody to be on medicine. So a tagline grabs attention, but what's the rest of the context is really important.
I think the whole spirit of integrated care has been this idea of how do we treat the whole person? How do we broaden the aperture to capture the complexity of human life and human behavior? And that includes a combination of medications and conversations. And in the press release, it talks about provide family support and psychotherapy and nutrition. I'm glad Ashley's here. And all of these things are prescribed. And then the solutions that they really begin to talk about are there are new prescribing guidelines and there's peer-reviewed prescribing protocols, right? So they're saying, okay, we have a level 10 problem and here's the solutions, but they're kind of giving us level 1 resources, right? Which is to go back and read and do more studies and consult these people. And in the average turn of a day for a primary care provider, pediatrician, family medicine, women's healthcare on the front lines, this is really hard to do. So I like the sentiment, but I don't see the legs underneath.
I wonder, Mary, we're sharing a lot of our thoughts. One of the reasons I'm glad you're here is bringing a different perspective too, as a psychiatrist, and that background of being a pediatrician as well. And I'm curious to hear, what is the conversation that you're hearing, not from us, but in the circles that you're in or in the work that you're doing? And what is as we're questioning context, what is the background that we may even not be seeing or aware of?
What you had said earlier really resonated with me. There's good and bad mixed in together, which is probably intentional. When I read this, I was looking at it in two ways. One is, what was the content? What did the words say? But then the other thing was, what was the real message? What ended up with the real message? And I think that's what you're hitting on here. What has really struck me from going in from primary care, when you're a pediatrician, you get to take care of families in happy times with babies and kids. They don't just come in for illness. And it's one perspective. When I was starting to see mental health problems, that's when I went into psychiatry, which developed in a whole different way and is pathology. And that's probably why I ended up in the integrated care, because I feel that very much there's something that when I was training, I thought, gosh, I wish I'd had my hands on these kids earlier. We could have prevented so much. So I think there's a lot to be said for starting holistically with wellness and development. And it's easier to talk about that with kids than when adults are coming in as new patients, although adults were all kids once. But so I think there's something to be said for looking at the whole picture and to work with wellness and other things and not just medicines. The other thing is that a lot of my work, because I see people who have not worked with, quote, straightforward medicine in the clinic or therapy alone or whatever, and the role of trauma has just been astounding to me. And it's either trauma or what I found over time is it's been atypical development. So people on the autism spectrum, so very subtle that people don't understand it, but they are getting day-to-day micro traumas really from not being able to fit in. So when you look at childhood mental health problems, I didn't say mental illness, mental health problems, the vast majority of it is experiential. And so you don't treat that with a medicine. And so these other things about giving supports and giving services, and heavens, just routine therapy should be part of routine well care anyway. It would benefit everybody. But the people I see, the experiences they're having are exacerbated by poverty. And they're traumatized by school shooting drills at school. So they're traumatized by the news, and kids who are gender nonconforming, which is a real biological thing and not an optional decision. They're terrified to go to school because they hear the hate speech. So I do think stepping back and getting a fresh take on it, the optimist in me feels there's opportunity here. And at the other end is that the real message was to make people emotional. Some of the statements, SSRIs are not more addictive than heroin. They're not addictive, but there's a fear and a stereotype that medicines used for mental health are doing something to you, and that people use benzos and things and stimulants, even though they aren't addictive the way they are prescribed. People do have that fear, and this is no doubt plugging into that and exacerbating that. And the SSRIs are not causal to mass shootings. That's been studied a lot. So my concern then at the other end of it, the pessimist in me, is the damage this is doing, just the fear-mongering about healthcare that there's already a stigma about. There's a stigma about mental health that is different than other parts of healthcare, and that extends to medicines, and it extends to probably the providers who prescribe those medicines. So it is up and down and a wide spectrum of what this encompasses, and a lot of layers to discussing it and figuring out how to move forward.
Yeah, there's just to let the audience know, especially if you're not in healthcare, it is actually really hard to keep people on medications. Really hard. So the average patient who gets started on an SSRI does not complete the recommended course of treatment with that SSRI. The average patient. It is difficult, actually. And it's similar, it's true also with kids. It's not easy to keep kids on medications. Sometimes it's tolerability issues. Sometimes there's just lifestyle issues. Sometimes there's financial issues. There's all sorts of barriers that actually keep people from getting on and keeping on these medications for the recommended course of treatment. I think it's just important to name that out loud. That's the lived reality that we all have in a primary care setting. And to your point, Mary, I think it's the context matters here, because talking about de-prescribing without talking about the structural issues that keep the health system from being able to provide the support services for patients, whether it is trauma-informed care, whether it is psychotherapy, whether it is an integrated care program at every primary care clinic across the country, whether it is social issues like poverty or immigration issues. If a kid is scared to go to school, his parents are scared to send them to school because of those issues, all of that's going to affect the kid's mental health, right? So where are we providing support for those things if we're not going to be, again, we're working towards over-medicating kids? That's the thing I think that's missing from the messaging. And it's pretty glaring for those of us in healthcare, because it's like, so you want to take a tool away, but you don't want to give us easy access to the other tools.
Yes. Yeah, that was my beef with the whole thing. I felt, okay, so you're critical of a tool that sometimes helps a lot of patients, but then we're left with, but how do we deliver the non-pharmacologic behavioral interventions? It's integrated care from where I sit, but that is far from reality in most primary care practices in the US. So I'd like to be seeing more national attention on how do we deliver on that step 2 part of non-pharmacologic. You need to be talking about infrastructure and billing mechanisms and education so that PCPs just think of a care team helping their person. So they're not relying on just a medication. Because for a lot of pediatricians, the access to psychotherapy, behavioral interventions isn't there. So again, if a tool could be medications in a context where it's helpful and not over-prescribed, I think we need to support that. And I do feel that some of the talk on this can be contributing to stigma and medication hesitancy when, like Neftali said, it's already hard enough to get people to consider a treatment option that might help them if there's concerns. And this, unfortunately, I think adds fuel to some of that fire.
Yeah, I think about our 3-world view of integrated care, right? And we have to think about, yes, there's the clinical, there's the operational, there's the financial, and even to give a credit. Part of this press release, as they're talking about these strategies, is to have more billing codes for education, for the lifestyle intervention piece, for intervening around these behavioral skills. But then, like, we know from working in integrated care implementation, who, how, when, because I look at Jen and I know that you are talking to your patients about all of these things. And just having a billing code is helpful. It is helpful to be able to add that, but who's going to pay for it? In what time are you going to do it? How are you going to fit that into the larger system? So it's like there's two levels where we need to be talking about the systemic context that's implementing things. Absolutely, there are the huge macro social problems that we're discussing, and to ignore those things really puts the blame on the person, the patient and the provider, who are doing the best they can swimming in this water that is such a problem. And there is like this meso level of just like implementation systemic things that we have to think about, of, again, the timing and the practicalities of the who and the how. Those are both big pieces. And Monica asked a great question in the chat. I'm just going to steal it from you, Monica, since I'm talking right now, but I'll give you credit. To Mary, I think we have this conversation a lot about, okay, but then what do we do? What do we do? I'm one person sitting in this office in Oklahoma who sees this number of people, and there's these huge social problems, and I can start to feel really powerless in the face of that. And so I'm curious if, from a psychiatric and pediatrician standpoint, how do you address or engage with these larger systemic issues that are coming up for patients?
So simple questions. So complicated questions
I know.
and variable answers. It's interesting because if you really have a patient-centered approach, if you really meet people where they're at and figure out what their need is in that moment and work with them, you learn a lot. And I think that what I've learned is I'd been in a setting where the primary relationship and watching families grow and being with them had been a big piece of it. And then I went to a setting where it was atypical stuff going on, and realized over time where I landed in the middle is and am the most effective is kind of back to that primary care approach, talking about the problem areas. And so that's part of why my path has been unusual. That and my ADHD that is partially treated, probably, but getting the grants where we haven't had to bill for the services. And so you can sit and you can talk to the patient and not have any goal by the end of the appointment other than that they felt safe during the conversation and that they were engaged. They knew that they could come back, that they had questions answered. And I tell them right off the bat, I'm not here to land on a particular diagnosis. I don't get kickbacks from the drug companies or any of those things. So it really has hit home that this therapeutic relationship, which actually is just human to human relationship, giving people dignity and letting them know that they're heard and have input is the number one thing. And unfortunately, that is so simple that people don't want to take it seriously because they're scared to death. No, it's what we call technical solutions for what's really needed is a transformational solution. And so that's been hard to kind of preach, even in primary care settings, who really in their hearts know better. But I think their own fear thinks, no, I've got to learn something more, get a new skill. And a lot of it, this surprises me about de-prescribing because I have trouble teaching people what are the basics that you need to know and keeping it simple. So that is why I've landed in an academic setting in an FQHC, which is able to give a little bit of wraparound and support services. And I've done a lot of, I'm sure we all have, donated a lot of time in conversations in communities and schools and things like that, and tried to pursue things a lot through partnerships and professional settings and working with some of the educational conferences. And I'm sure all of you have done those things as well. So it is exploring what you have the opportunity to do. But I think it's all driven by caring about the person in a human and respectful way and realizing the advocacy they need because they feel like they haven't been heard or they haven't had input, or people didn't realize the trauma, how it affects executive function, and wouldn't the business model of medical care doesn't tolerate no-shows and things like that. So that on the one hand, it's very simple. It goes down to the basics and you always start there. And if you don't, you're not going to be effective no matter what else you do. But then on the other hand, how you move that transformative understanding forward, you have to explore what are these other things, because the traditional medical system, as we practiced, it's a business model now. It's transformed. I'm old enough, I remember when it wasn't exactly like this, and it has transformed so much. We have to look for things outside the typical medical business model for sure.
I think it's something that we talk a lot about here, is moving from a transactional way of working with patients and their families to a relational way of working with patients and their families. And you're absolutely right to call out that requires systemic transformation of the system. The system has to orient itself differently. And in some ways, ironically, I do think that at its core, that's part of the fear that the folks who get behind this are responding to. I think when they see their commercials littered with drug company advertisements, when they go see their doctor who has 7 minutes to talk to them and end up with 3 medications they feel like maybe thrown at them, right? It's not hard then to see, oh, this feels as if I'm a consumer mark, right? Like I'm being marked for targeting by this system. But then there's us, right? And we are pulling in the opposite direction. We're saying teams take better care of patients. We're saying patients need to be treated in their contexts. We're saying that patients should have an array of options available to them, and team members who have different expertise are going to be the ones that are better able to offer those, right? And I think that's where integrated care has, in this community, has an important counter message to that transactional approach that you're talking about, Mary. And speaking of which, I want to bring Ashley into this conversation because another core piece of the Maha movement that is related especially to kids is the nutritional piece, where there is this sort of almost magical understanding that what you eat will solve your problems. I'm wondering, Ashley, if you can talk to that, whether you've experienced some of that conversation, because I think that's part of the de-prescribing thing. It's you don't need these medications that the pharma's given you. What you need to do is just use sort of natural things.
Yes, absolutely. But before we talk about that, and I love talking all things nutrition, I do want to circle back to exactly what all of y'all have been saying, that my heart breaks that you don't have this same sort of team that my wonderful practice in their 60 years of being primary care pediatricians for these counties. They saw exactly what y'all are noticing in that, hey, this kid needs therapy or needs to see a psychiatrist or a psychologist. And sure, I write the referral, but it's 3, 6, 9 months before they're getting the help that they need or before they can get in to see someone, which is where the origin of our care team a few years ago really started, where it was 1 or 2 people. I want to share that we now have 2 licensed clinical social workers in our offices that do psychotherapy, COCM. We have also brought on 2 referral and care coordinators who are really the doctors or the PAs or NPs are saying, hey, they need this. They're the front line. They're trained in triple P. They're trained in, hey, who is the best person? What do you need? And really triaging very much in the same way that nurses triage, whether it's over the phone or portal messages, whatever, for our medical practices. And really those LCSWs and referral and care coordinators are the sort of bridge, as we like to call them. If somebody can graduate with just that, amazing, wonderful, we've done our job, beautiful. But if they need more, they don't let them go until they are safely in the hands of whomever expert needs to see them and help them, whether that's a psychiatrist, psychologist, etc. So I just wanted to really give kudos to my practice because it's unlike anything I've ever seen or experienced and truly one of a kind. And I hope, I say this every episode, I hope that it just becomes the mainstream for everyone, but especially for kids. And the nutrition piece, Neftali, to just really, they brought me on when they had that really organized and set and run beautifully. And they found, great, now we're helping them with their mental health and their physical health. But there's this nutrition piece that, again, was we can send a child who's morbidly obese with maybe a elevated A1C, has prediabetes, hypertension, all of these things to a big name facility, but they're not being seen for 6 months. So what's happening from the time they leave our office until they see that provider at that big name facility, and what changes are really being made on one visit, right? And so I cannot express to you enough, and I say this to my kids all the time, my patients all the time, is that I work with kids because, and this is no ugliness to adults, y'all are great too, but it's really hard to get an adult to change something that they've done for 20, 30, 40, 50, 60 years, whatever it is. With kids, they are eager for knowledge and for any sort of independence and for choices. And I love that I get these minds, and it's never about you need to lose weight or you need to this. I really bring it to the science of, hey, what we put in our body and what we fuel is what helps keep us healthy and strong. And I really like to find out what they want to be, whether it's a firefighter, or a doctor, or a nurse, or an artist, or I have one patient that wants to be a rock star. Pop off, queen, but you cannot put on a 4-hour show on sugar alone. It's not going to cut it. And so I think that's the piece that if we can truly target and help these children at regardless whatever age they are, 2, 4, 7, 10, 15, 18, 19, and help them. And I help them to understand that the changes they make now are going to help them for the rest of their life. They may not need to be on medication for diabetes, high blood pressure, heart disease. They'll be able to do the things that they want and love to do for longer because they will be healthier. And so I don't think there's any better, easier, more eager patient population to work with than kids. And I also am obviously very passionate about them. I love them dearly, but
Well,
I
I
really
don't
think
agree, Ashley.
that's just my point, Miss Monica. That's just my
Oh,
point. But
well,
tell me, talk.
here's what I give so early childhood educator here, former teacher, taught school many years, worked with the whole spectrum. And one of the things that I have always said as adults are like big kids too. And it's never too late to learn and have a behavioral change. And the thing that always got me and still gets me when I work with kids, because I still do work with kids, is you can plant seeds with kids that sometimes can't grow until they get out of their parents' house. Because if you're not also planting the seeds with the guardian or whoever it is that is taking care of them, you're doing a little bit of injustice. So if you think you're going into peds to just work with kids, you're mistaken. You will inevitably work with entire families, and that means those adults that are there. And so when I think about the nutrition side of what was in the brief, as soon as Neftali said it, I was like, yes, Ashley needs to respond first. And I instantly thought, that's good. You can tell me what I need nutritionally, but if I can't afford it, or I don't live in a place where I can easily access it, you could tell me all day about how I should have these organic things and these grass-fed cows, and you can tell it to me all day long. But it also costs more. And if I can't financially afford it, then guess what? No, I'm going to go buy the hot dog pack. That's a hodgepodge of everything. That's 99 cents from the store.
100%. And that's where I agree. And that's where I come in, where I have never asked anyone I don't eat organic. I've got 3 kids but what makes sense and what bigger picture can we focus on? So I tell my kids, I don't care if you're eating air fried chicken nuggets versus grilled chicken. If that's what works for you, or tuna fish in a can, great source of protein, or yogurt. I'm talking the Food Lion low fat Greek one that tastes like vanilla because that's the best flavored one. Or if you are going out to eat because McDonald's or Burger King or whatever is all you can afford, that's amazing. Let's make the best choices and let me give you options so that regardless of what your scenario is, that you can try to make the best choices in whatever instance that is, for sure. And veggies too. I don't buy fresh vegetables and fruits. I say I love canned green beans are my favorite. Anything frozen, I love it because usually it's cheaper, it lasts longer. And a lot of these kids and their families, it's not 1 or 2 people that is in the house that we are purchasing for, right? It's families and maybe aunties, uncles, grandparents, cousins. So to your point, 100%, I will share in my experience when I worked just with adults, where it wasn't a family setting. I worked a year in outpatient adults. They would hear me, but whether they believed me or actually made the changes was where I found the most difficulty. I find that when I'm speaking mostly to the child in my sessions, and of course their guardian, their parent, their grandparent, whomever is with them and caring for them is there, they're hearing, and you can see the wheels turning as well, because I make it very clear this is not just applicable to the child, this is applicable to all of us. And some parents and families take it and they run with it, and the whole family is making better choices with whatever means they have. And some people don't. And that's okay. And that's the work that we do, where, again, we give them the skills and the tools and what they choose to do with that after the fact. I guess what I'm saying about the kids is that they are a little bit more excited to see me and a little bit more eager to learn. Not that the adult population is not. They just seem, and they keep wanting to come see me. That was one of my biggest struggles with the adult population. Okay, you said what you had to say. Bye. I maybe do it, I may not. And the kids want to keep coming to see me. So that's where it makes my job a little bit easier for sure.
I think what you're naming, Ashley, and what we're all agreeing on, and is also part of why this is a struggle to engage with these recommendations, right? Is that, yes, we're centering relationships, we're highlighting the values of the person, highlighting their goals and their objectives. And there's that fear in the background, I think, and what you were expressing earlier, Mary, and what I I'm hearing for all of us and what are the implications? So if there's fear driving our patients engaging with us, or if there's mistrust being seeded, where does that take us? Because we are all in agreement with, yeah, we need to be making healthy, nutritional, supporting changes. And when that goes so far is coupled with a mistrust in prescribing, or like just verifiably false information about risks that don't exist for things that can be critical tools, it's not a far leap for people who don't have your training and education and background to be like, oh, so I just need to stop eating red dye and then all my mental illness goes away. Or I just need to keep this paleo caveman diet and then I'm not have any more anxiety. And so there's this like false conflation that happens. And so that's just such a struggle when we bring it back to that big picture. And then maybe that's part of our answer too, right? I loved, and I want to come back and I want to blast over all of our channels, Mary, the message that you were saying earlier about like, it is not a simple question and there's not a simple answer. And yet the recommendations are pretty straightforward. Come back to relationship, focus on what we can do in that moment, engage in community, engage in advocacy. Don't get so overwhelmed with the problems that we feel helpless to make the impact where we are. And I'm rephrasing what you said, and I think those are so critical. And also, it's really hard.
Yeah, Mary, I wonder if you could help us by helping us think about, so we've been talking about de-prescribing, and that's like a negative message, right? It's let's take something away. But you're giving us a more proactive message. Let's move towards relationship. How can we do that? How can we champion that, say, in our systems, right? You're in a big academic medical setting. Other folks might be in a small FQHC somewhere or in a community mental health center. How do we champion this notion that in relationship, we can make better decisions together as providers and as patients and families?
Boy, I wish we could prescribe friendly, supportive, respectful relationships. I get into this a lot through the trauma-informed care work. And if you think about it, it's all about just putting yourself in the other person's shoes and where they're coming from. I also work in the medical school with the leadership program. And we do a lot of training on communication and emotional intelligence and traumatic reactions and things like that, which I think people are more interested in now because of the burnout that people are feeling and a lot of the trauma from COVID and a lot of this distrust and mistrust of the medical and the healthcare profession in general. It really was going right along with COVID or developing at that time. And so this has been something that people have been trying different ways to respond to. We work a lot with the provider themselves understanding how they're feeling, because how we're feeling, how the patient makes us feel will determine how we treat the patient. And so we get in there, it's about you. It's really about the patient. It's about both of them, because if you have a good relationship with your patient, it's healthy for you too. And we know now that these trauma and stress responses are physical changes. It's not all that psychological maladjustment. It may be part of that. There are messages from what we experience, but there are very physical changes. And so people who are flooded in the fight or flight response, which is easy to do when you're in a clinical setting as a provider, you're going to need to interrupt that at time. So that's how we're getting into a lot. Some of those, it's hard to have some of my surgical subspecialists really sit and try box breathing to interrupt their hyperactivated sympathetic nervous system until they find it works. And so there are different ways people get into it. Part of it, I think it's a combination of what's your opportunity and what's your relationship with the people you're going to be working with. Who do you need to develop your relationships infrastructurally? But it's not just opportunistic. You have to have kind of an intentional script, isn't the right word, but some kind of a plan or something definable to go on, if that's what you were asking.
Yeah, no, I love it. It's fascinating that's what you went to, because A lot of what we've been thinking about here at CFHA is investing in our leaders and supporting our leaders to create this change towards systems that care for patients and families in this holistic relational way. And one of the things we're doing is actually working on a coaching service, because we feel like our folks don't need therapy per se, but coaching is a vehicle that we think our leaders and our healthcare providers need to be able to face these issues that are very traumatic, difficult issues in their spaces. Sometimes it comes from the organization, sometimes it comes from the patients and these difficult conversations and the mistrust and those dynamics. So I think it's interesting that you're pointing in that same direction.
We all discover the same truths, right? If the
Yeah.
truths are there. I do have to say that part of the reason I took this more glamorous head of leadership and excellence position is people listen to you differently than they do of, oh, you're that psychiatrist, that kind of thing. So I think being aware of how people perceive you, people will not necessarily come for coaching because they're struggling, but it's leadership coaching. They're all over it. How we message to the people we work with is very important. We all have our own fears and our own internal biases and our own things that we want to achieve as well.
I think that being mindful of our time, and so much for a shorter podcast, listen to us on super speed if you need to. But as we're getting ready to close, that kind of comes back to my question too, of like, how do we take the good in there's good and with the bad? How, with this recommendation, even specifically, what does it look like to take the good? How do we come alongside and figure out where we can join up with the good parts? How do we release and let go of, or more than releasing and let go of, but advocate against the pieces that feel like they're going to be detracting or counterproductive to the mission that we hold and the view that we have of healthcare and our patients' healths and our systems? What does that look like?
I'm going to point to my friend Deepu here because he put something in the chat that I love. I think we need to have a positive message, not just an against message, right? So Deepu, can you speak to the hashtag prescribe this message you put in the chat?
Yes, I was just paraphrasing what Mary was saying, which is in a system that is so profit oriented, can we also then in the spirit of the good parts of what the recommendations are saying, can you prescribe friendly, supportive relationships as the solution, which is time and resources? And as Grace was saying, how do we take in the good parts? I was like, I feel like the good parts are great, and it demands an investment in infrastructure and rethinking how we deliver healthcare, right? And which is to give providers and teams more bandwidth to have confidence in how they send a patient home, right? And I think one of the big promises of integrated care is all the things that we believe in and rave about, but in a very practical day-to-day, in the trenches of a patient that is very difficult to engage, or structural issues that are holding them back or whatever, the confidence the team has is that we all work together to give them another day before we see them again, right? We didn't really solve a lot of problems. We held each other and held them with the same dignity and hope that we want everybody else to hold us in. And so I think my takeaway is what Mary was saying, which is to prescribe the relational features that we discussed here as part of the solution. And then how do we do that? I think the infrastructure needs to be brought up to receive those recommendations.
It's awesome. Yeah, we need space for teams, we need space for relationship, and the system and the structure has to provide that space. And in that context, we can have good conversations about the appropriate use of medications and the appropriate use of other interventions and strategies that we might use. Absolutely.
I'm so thankful for this conversation. I think it's both given me a lot to think about, and also encouraged me to remember to stay focused on the person in front of me, stay focused on the work that we're doing. And in the metaphor that I use a lot of times with my students or my different learners, we're just placing a brick. We're not building the whole house right now. And so I hope that's a takeaway that we have. Mary, I can't thank you enough for being here with us and sharing your experience and your passion and the voice in this that you have in this work that you've done. Just really appreciate you taking the time with us.
It is a pleasure and a privilege to be included with your group this morning.
And I think, Deepu, we have a kind of a closing thought the way we often do.
Yes, we do. This is a short paragraph that comes right at the end of Upstream, which is Mary Oliver's first essay in a collection of shorts that really expresses her trajectory towards nurturing our creative spirit and reconnecting with nature. And it has a little bit about children too. So here it is. Teach the children. We don't matter so much, but the children do. Show them daisies and the pale hepatica. Teach them the taste of sassafras and wintergreen, the lives of blue sailors, mallow, sunburst, and the moccasin flowers, and the frisky ones, inkberry, lamb's quarters, blueberries, and the aromatic ones, rosemary, oregano. Give them the peppermint to put in their pockets as they go to school. Give them the fields and woods and the possibility of the world salvaged from the lords of profit. Stand them in the stream. Head them upstream. Rejoice as they learn to love this green space they live in, its sticks and leaves, and then the silent, beautiful blossoms. Attention is the beginning of devotion.
Thank you, Deepu. Thank you, Mary, for being here with us. Thank you for all of my co-hosts. Thank you for our listeners. We'll talk to you again next month.